May I now invite Dr. Pankaj Hans at the podium, please? Timer reset.
Honorable Chairpersons, respected seniors and dear colleagues, the topic of my presentation is donors with viral infections, particularly hepatitis B, C and HIV, that I shall be discussing under these headings. Now, what are these donor-derived infections? They are defined as any infection present in the donor that is transmitted to one or more of the recipients. It can be expected or it can be unexpected. The unexpected infections occur in less than 1% of recipients. And to mitigate this risk, the combination of serological and nucleic acid testing is needed, but in spite of this, the residual risk still remains. So how to do this risk mitigation? It is done by serology test as advocated by most organ procurement organizations, can further be added by NAT or PCR, but in spite of this, we can miss few cases because hemodilution, because of blood transfusion, large volumes of IV fluid infusion can result in false negative results. During eclipse period, that is when the donor is infected, but the virus is not detectable, also we can miss these infections. Advantage of nucleic acid testing is that the window period is reduced to a greater extent. Now coming to the first, that is hepatitis B positive donor. If we discard all hepatitis B positive donors, the incidence of which is about 4% in our country, the donor pool will be dramatically reduced. So we have to categorize these patients into acute infections, chronic infection, whether the infection is resolved, whether the patient is vaccinated, the donor is vaccinated or not. And then we can just divide into two groups. One is deceased donor cases. We use HBsAg and anti-HBc as the screening tool. And in endemic areas, we add HBeAg and anti-HBeAg to it. And this is about the errors in the serology that we have already discussed that can be mitigated with the uses of nucleic acid testing. This nucleic acid testing, most of the countries, they have adopted this test as the accepted one for donor workup. Advantage is that the window period is reduced from 35 to 44 days to 20 to 22 days. Demerit is that it is expensive and not easily available. So what are the donor aspects? If the donor is anti-HBc positive, the risk of transmission is very minimal and there are no symptoms of hepatitis and no excess mortality, as I will show in further studies. But the main concern is HBsAg positive group, that is the main challenging one. So we have divided into two groups, risk factors and protective factors. Risk factors include the viral factors that we have just discussed. If the recipient has been used with ATG or rituximab, then the chances of infection in the recipient is higher. Prophylaxis includes hepatitis B vaccination, uses of hepatitis B immunoglobulin, and antiviral drugs and vaccination of the recipient also. There are several studies, to quote a few. This study is from China upon 83 kidney transplant recipients and has been shown to have excellent graft and patient survival without excessive hepatitis B transmission when compared to the control group. And in all these patients, the anti-HBs titer was more than 10. These two studies further substantiate the same findings that the chances whether there is not increased risk of de novo hepatitis B infection or active liver diseases. So this can be how to monitor the recipients. American Society of Transplantation recommends that liver enzymes, HBsAg and HBV DNA titer every 3 months should be used for 1 year, and subsequent management should be based upon the results of the first year. And the patients who are NAIF, they should be vaccinated even post-transplant. And those whose titer is less than 10 milli-international unit per ml, they should be vaccinated. The titer falls after transplantation, so it should be monitored and patients should be revaccinated. Uses of hepatitis B immunoglobulin that provides passive immunity, and it is combined with nucleoside or nucleotide agonists. Lamivudine is not that frequently used these days. It can be divided into 3 ways. One is patient is both HBeAg positive and HBV DNA positive. Just discard these organs. if the patient is 𝐻BeAg negative and 𝐻BV DNA negative, then just divide into whether anti-HBs titer is more than 100. You can optionally give the patient any nucleoside agonist for 3 to 6 months in the recipient actually. And if 𝐻BeAg and 𝐻BV and titer is more than 10 but less than 100, this optional treatment, the duration is up to 6 to 12 months in that case. So that way you can just stratify your patients. 𝐾DIGO also recommends the same. The addition is that 𝐾DIGO now suggests that interferon treatment should generally be avoided in hepatitis B infected kidney transplant recipients and screen HBsAg positive patients with cirrhosis for hepatocellular carcinoma every 12 months with liver ultrasound and alpha fetoprotein. Other things remains more or less the same. And this a long-term study has also shown that 10-year graft survival of such patients, the graft survival is 84.6% and patient survival is 92.8%. So summarizing about hepatitis B, kidney transplant donors with hepatitis B donors is not a risk-free procedure. So careful allocation to appropriate recipients can be successfully performed. Coming to hepatitis C cases. Previously, hepatitis C donors, they used to just donate their organs to only hepatitis C positive recipients. But now with the availability of directly acting antiviral drugs, they can donate their organs to both hepatitis C negative as well as hepatitis C positive donors. Now, if a donor is HBC antibody positive and NAT negative, then they can easily donate their organs. And this is the recommendation that all donors should be tested with NAT, hepatitis C antibody positivity and NAT negative kidneys. They can be safely transplanted into both hepatitis C negative as well as hepatitis C positive recipients. And if hepatitis C positive donors, the organ has been transplanted to hepatitis C positive recipients, the directly acting antiviral should be implemented as soon as reasonably possible in the post-transplant setting, or it is better if in the pre-transplant period the donors are treated and SVR is achieved and then transplantation is done. And in hepatitis C positive donors in NAT negative recipients, the antiviral drugs, that is directly antiviral, can be used in a prophylactic, preemptive or delayed way. Each has got its own merits and demerits because of paucity of time, not going into the details. And for the treatment of HCV in kidney transplant setting, nowadays with the availability of pan-genotype drugs, this sofosbuvir and velpatasvir is the commonest combination that we have been using, but sometimes we get resistance to it. The recommendation is to add voxilaprevir to it, and then we can achieve 98% sustained viral remission. 𝐾DIGO also recommends the same. Only addition is that after assessment of liver fibrosis, HCV infected potential living kidney donors who don't have cirrhosis should undergo hepatitis CV treatment before donation if the recipient is HCV uninfected. Summarizing this, transplantation with HCV viremic donor followed by directly acting antiviral treatment is still cost effective compared to dialysis. Coming to the last part, that is HIV positive donors. With the passage of HOPE Act in 2013, now HIV positive living and deceased donors, their organs are transplanted to HIV positive recipients easily. The risk is superinfection. The recipient is affected with one strain of HIV and the donor is having another strain of HIV. Chances of superinfection is there. It can be resistant to the antiretroviral what the recipient has been taking. So this has to be taken into consideration. Plus the donors, they are at increased risk of kidney disease compared to the general population. That is why all HIV positive donors, as a protocol, they undergo biopsy before donation. And kidney disease affects up to 1/3 of those affected by HIV, and it is attributable to combination of HIV-specific factors, nephrotoxic ART, and as a result of comorbid conditions. The best predictor of ESRD after kidney donation is the baseline risk of ESRD. And there are certain nephrotoxic antiretroviral drugs like tenofovir disoproxil fumarate that causes mitochondrial damage in the proximal renal tubular cells, particularly in diabetics and those having pre-existing kidney diseases. Similarly, atazanavir and lopinavir increases the incidence of CKD with time. The answer to the use of tenofovir is the use of tenofovir alafenamide, which is not nephrotoxic, and that has revolutionized the treatment. Genetic factors are equally important. A POL1 gene predisposes to development of collapsing variety of FSGS that manifests as kidney failure increases the incidence by 7 to 10 fold. These things we have already covered. The benefit of HIV organ donation is the sense of altruism, sense of solidarity, and decreased stigma associated with HIV. So if there is a living kidney donor eligible, the criteria for donation is he should have a confirmed HIV infection, well-controlled HIV infection in the form of CD4 count more than 500 for more than 6 months before donation, HIV plasma RNA less than 50, and no evidence of invasive opportunistic complication. Pre-transplant donor organ biopsy should rule out any further increase in the chance of ESRD in such patients, and you should have a detailed antiretroviral history of these patients. These donors, they can have the outcomes like progression to renal insufficiency in future. They may require changes in their antiretroviral drug. They may even progress to AIDS, and they may even die. So immunosuppressive protocol in these patients, most centers, they use tacrolimus as the first line CNI, but there are no studies that compare the effects of tacro with cyclo. Patients treated with protease inhibitors, the lower dose of CNIs are to be used because the level is increased. MMF actually increases the intracellular level of tenofovir. MMF has got inhibitory effect on HIV replication in multiple studies, and mTOR inhibitors that decrease the incidence, prevents the solid organ transplant associated malignancies. So carefully it should be done. ATG to be avoided because it increases the risk of infection. Overall, the graft survival and patient survival is quite satisfactory. This is a high risk behavior of the patient. Previously in 2013, it was 12 months follow-up. Now it is only 1 month follow-up is needed. Now, when to screen a patient, just one slide is remaining, just when to screen these patients. Deceased donor 96 hours before organ procurement. Living donor as close as possible to the surgery, but not within 28 days actually. Our transplant candidate pre-transplant after hospitalization, and post-transplant 4 to 6 weeks after transplantation. Summarizing, nothing new. So concluding, although organ transplant is considered a life-saving event, it is not without risk. Risk of unexpected donor-derived infection is just 0.1 to 0.2%. Donor screening can mitigate the risk of disease transmission, and discarding organs due to fear of disease transmission may result in more adverse outcomes, including death, than the rare transmitted infection associated with transplanting with these organs. And thank you very much for your patient listening.
Thank you, presenters. It was an excellent session. There is no questions because of the want of time. You can discuss with the presenters during the tea time. Thank you.